So today we're going to discuss about the dermoepidermal junction, and there are a lot of disorders which are associated with the dermoepidermal junction. Today, in particular, we'll be discussing about one of the most common and important disorders, that is epidermolysis bullosa. So, like the term says, it's self-explanatory. Dermoepidermal junction is an area where the epidermis is connected to the dermis, and it has a lot of structures. So let's study these structures one by one and look at the genetic components. So it's a junction between the epidermis and dermis, and it is a highly complex form of basement membrane. So this dermoepidermal junction, which is also, so the short form of dermoepidermal junction is the DEJ. So the DEJ is a highly complex form of basement membrane. So it is not seen with a normal H&D stain on a microscope. So there is a special stain which needs to be done to visualize this dermoepidermal junction, which is known as the PAS stain. There is a periodic acid shift stain. So the thickness of it is 0.5 to 1 millimeter, and the surface area is around 1 to 2 meters square. So what are the functions and why do we have to study about the dermoepidermal junction? So it has a key role in forming attachments between the epidermis and the dermis, and it forms as a vehicle for the cellular attachment and also for the transfer of material and molecules between the epidermis and the dermis. And it also acts as a moderator of cellular activities. So we'll see how the dermoepidermal junction does each one of these things later on. So this is a very, I know it may seem very daunting at first when you look at this diagram, but each word here and each of the components here is of value clinically. So it's important for us to properly decipher this diagram. So this is basically the dermoepidermal junction. So it has mainly 4 parts. We'll break down these things. The 4 parts of the dermoepidermal junction are, the first one is known as the Hemidesmosome. This is the first part. The second one is the Lamina Lucida. The third one is the Lamina Densa, and below that is the Sublaminar Densa. So these are the 4 structures of the dermoepidermal junction which we need to know: the Hemidesmosome, the Lamina Lucida, Lamina Densa, and the Sublaminar Densa. So you can see a lot of structures and a lot of letters over here. So this Hemidesmosome, again, I'll tell you about it in detail. So these are the 4 regions of the basement membrane zone on the dermoepidermal junction: the Hemidesmosome, the Lamina Lucida, Lamina Densa, and the Lamina fibroreticularis is nothing but the Sublaminar Densa. So this is nothing but Sublaminar Densa. The other term for this is Lamina fibroreticularis. Okay, so the first structure which I told you was Hemidesmosomes. So again, Hemidesmosomes have 3 structures: the inner plaque, the outer plaque, and the subbasal dense plate. So let me just show you this. So this is the inner plaque of the Hemidesmosome. This is the outer plaque. So this is the outer plaque, and this structure which you see here, this line, this is the subbasal dense plaque. So yeah, you'll be able to understand it better over here. So this is the inner hemidesmosomal plaque, the outer hemidesmosomal plaque, and the subbasal dense plate. So all this is not just theoretical. Each one of these structures here is associated with a particular disorder. So it's very important for us to understand this. So as we can see here, the inner hemidesmosomal plaque has 2 structures, plectin and BP230. The outer has 2 structures, BP180 and this integrin. And the subbasal dense plate is basically like an anchoring plate. It does not have any relevant structures, but these 4 things, plectin, BP230, BP180, and alpha-6 beta-4 integrin. So we need to know what exactly these are and how they are important to us in dermatology. Okay, so plectin. So So all of them are basically structures, and mutation of each one of them causes a particular group of disorders. So most commonly, like I said, the disorder which comes out of any defect in the dermoepidermal junction is epidermolysis bullosa. So there are a lot of types of epidermolysis bullosa, which I'll be talking about later. But for now, just remember that mutations of plectin causes something which is known as epidermolysis bullosa simplex. That is all we need to remember. Nothing else. Epidermolysis bullosa simplex, which is also known as EBS. Epidermolysis bullosa simplex is caused by a defect in plectin. So BP230. So this BP230 was this structure. So this plectin gives rise to epidermolysis bullosa simplex. We'll add all the disorders in this diagram later on. So BP230 is associated with an autoimmune vesicular-bullous disorder, which is known as bullous pemphigoid. So many of you might have heard of bullous pemphigoid. It also causes epidermolysis bullosa simplex. BP180. So BP180 is also known as collagen 17. So there are a lot of collagens here. So let's not get confused. There is collagen 7, there is collagen 17. Okay, so both of them are structures of the dermoepidermal junction. So collagen 17, let me just go back to this BP180. This is also known as collagen 17. So there is another collagen 7 here. Collagen 7 comes here, and this is collagen 17. So let's not get confused between these two. BP180 is also known as collagen 17. So what are the disorders which arise due to mutations in BP180? Causes something known as junctional epidermolysis bullosa. So like I said, there are a lot of types of epidermolysis bullosa. I'll be talking about that later. Junctional EB is another type of EB, so which arise because of mutations in collagen 17. And it is also affected in a lot of autoimmune conditions like bullous pemphigoid, pemphigoid gestationis, mucous membrane pemphigoid. So all these, I'll be covering about all these autoimmune vesicular bullous diseases in maybe one of the further classes. But for now, just remember that collagen 17 causes junctional EB. So let's go back to this diagram. So this is a lot of autoimmune conditions. And junctional EB, okay? So integrin. So integrin was the other structure. Okay, so we studied about plectin, BP230, BP180, and now let's look into integrin. So integrin is caused by, integrin is made up of two particular chains. So they're called as alpha 6 and beta 4. And again, they give rise to something which is known as junctional EB. So like I said, EB simplex was one type of EB. The gene here was plectin. And junctional EB. So this is how we call junctional EB as JEB. So junctional EB is caused by defect in BP180, which is also known as collagen 17 and alpha 6 beta 4 integrin. Okay, so these are the things which we need to remember for junctional EB. Okay, so I hope that is not very confusing and overwhelming. Let's just go back to this diagram here, the very first diagram just showed you. Yeah. So this. Okay, so we studied about 4 structures in the hemidesmosome. BPAG1, that is also known as BP230, BP180, plectin, and integrin. So these are the 4 structures. This, and this. So this basically was your structure of hemidesmosome. Okay. So you can see a lot of overlapping here. There is a lot of overlapping with the Lamina Lucida also. So I hope these are the basic components of the basement membrane zone you should not forget. The four things which I said were Hemidesmosome, Lamina Lucida, Lamina Densa, and the Sublaminar Densa. Okay. So in the Hemidesmosome, the four structures which we studied were this. Now let's go to the next one, that is the Lamina Lucida. Okay. Yeah. So Lamina Lucida. Lamina Lucida, again, we already studied about this. So let's not worry about this. We already read about alpha 6 beta 4 integrin and 180. BP180 is nothing but BPAG2. So we already read about these two, and we already know that these two cause junctional EB. So what is new here is something called as anchoring filament. So this is the one structure which we need to remember in Lamina Lucida. So again, a lot of confusing things. So these are anchoring filaments. So there is another structure which is known as anchoring fibril, which we are going to see later. So just remember that in Lamina Lucida, it is called as anchoring filament. Okay. So the next structure after Lamina Lucida was the Lamina Densa. Okay. So Lamina Densa, as the name says, it is an electron dense layer. So here the major biochemical component is type 4 collagen. You don't have to worry about all the other structures. Just remember about type 4 collagen. So type 4 collagen, again, like I said, a lot of collagens. So there was collagen 17, right? Collagen 17 was nothing but BPAG2 or BP180, and collagen 4. So where was this? BPAG 180 was in the hemidesmosome. So collagen 4 is in Lamina Densa. And I told you about one more collagen. What was that? There was this. This is collagen 7. Collagen 7 comes in the Sublaminar Densa. So there's 17 here. Okay, there's 4 here and there's 7 here. So you need to remember again these three things. A lot of different types of collagen. Collagen 17 comes in the hemidesmosome, collagen 4 in the Lamina Densa, and collagen 7 below the Lamina Densa in the Sublaminar Densa. I know all this is very confusing, but it is very important to us clinically. So realize that when I talk about epidermolysis bullosa. Yeah. So Lamina Densa, like I said, mainly type 4 collagen. So these are all the disorders of some of the types of collagen. So what have I'm sure all of you know about these two conditions, Alport syndrome and Goodpasture syndrome. So that happens because of the basement membrane damage of the renal tubular epithelium. This is 4, collagen 4. So coming to the last layer, the Sublaminar Densa. So the Sublaminar Densa, we already read about all this, Lamina Lucida, Lamina Densa. So Sublaminar Densa has something which is known as anchoring fibrils. So this is why I said, remember that those in the Lamina Lucida, it was known as anchoring filaments. So both of them are totally different. This is the anchoring filament, and in the Sublaminar Densa, you have something which is known as anchoring fibrils. So all this can, come as a multiple choice question. Anchoring fibril comes in the Sublaminar Densa. So what is anchoring fibril? Anchoring fibril is nothing but the other name for collagen 7. I'm just going to repeat it again and again so that it's just easier. 17 was in the hemidesmosome. Okay, 4 was in Lamina Densa and 7 is Sublaminar Densa. So why do we have to study about this? Because the mutation causes something which is known as epidermolysis bullosa acquisita and a lot of other autoimmune conditions. So the main one which we need to know and which we are going to read today is dystrophic epidermolysis bullosa. I know all this was like very confusing. I hope it's going to be a little more clear when I show you some images of the conditions of epidermolysis bullosa. Okay, so epidermolysis bullosa is a very common genetic condition which is seen very prevalent in the UK. So we don't see many Indian kids, but there is a rising incidence even in India. So the more colloquial term for epidermolysis bullosa, so they're also called as butterfly children. So have you heard of the term butterfly children, or why they are known as butterfly children? It's because, like, if any of you have ever tried to touch a butterfly or hold it by its wings, so the skin or the wings sort of fall apart, and it actually gets stuck to your hand, and you can see the colors on your hand. So the wings of the butterfly are so thin and so frail and so fragile. So that is how the skin of these children are. So that is why they are known as butterfly children, because of the extremely fragile skin. Okay, so what exactly is EB? So for those of you who have not heard of EB before, it forms a very big part of pediatric dermatology. So there are more than 5 billion people, 5 billion children in the world with EB. So around 1 in 30,000 kids are affected by EB, and it can occur in all ethnicities. There is equal male and female ratio, and the main history which we need to take is a history of consanguinity. In first degree consanguineous marriages, there is a high incidence of epidermolysis bullosa. So it's mainly classified into 4 types. So I already told you about the 4 types very briefly: epidermolysis bullosa simplex, junctional EB, dystrophic EB, and there is also something known as Kindler syndrome, which I will tell you in the later slides. So there are a lot of genes which cause EB. So EB is caused by a number of genes. So the ones which I just told you are just the tip of the iceberg, or the majority of the genes. So there are hundreds of genes which cause EB. We don't need to know about all of them. So the purpose of today's class is just to give you an introduction to EB and what are the main clinical symptoms, and if a child and when should you suspect EB in a child. So EB impacts the lives of children and parents physically and emotionally, and it can cause a lot of deformities for the young child to live with. So that is why it's very important for us to recognize EB very early in life and refer them to a specialist where they can get the required care. So you can see in the slide, the last 2 lines in the slide, that there is no cure and no effective treatment yet, and research is the only key. So that's, I guess, true for most of the genetic conditions. Yeah, so this is again just to brush up what we just read and summarize the various types of EB. So this is the dermoepidermal junction which we just read. Okay, so there's the hemidesmosome here, right? So this is the Lamina lucida, Lamina lucida. This is the Lamina densa. This one. This is the Lamina densa, and this is the Sublaminar Densa. So what we need to remember is there are 3 types of EB: epidermolysis bullosa simplex, junctional epidermolysis bullosa, and dystrophic epidermolysis bullosa. So this affects the different layers of the dermoepidermal junction. So epidermolysis bullosa simplex affects the hemidesmosome and so these layers, the top layers of the epidermis. So the top layers is affected by epidermolysis bullosa simplex. So that is why it is known as simplex. So it does not cause a lot of deformities and a lot of scarring because the dermis is not involved. It's mainly in the superficial layers of the skin or mainly in the epidermis. So junctional EB affects the lamina lucida, whereas dystrophic EB affects the sublaminar densa. So the more further down you go, the more severe the manifestations are. So that is how you need to remember. The more superficial forms of EB, the one which affect only the epidermis, are not very severe. As we go further down, the manifestations are more and more severe. So just remember that epidermolysis bullosa simplex is affects only the epidermis. Junctional EB affects the lamina lucida, and dystrophic EB affects the sublaminar densa. And below the sublaminar densa is the dermis. Okay, so this is the epidermis. So this is the dermoepidermal junction. So okay. Okay, so there are a lot of types. Each type of EB, I told you about the three major classification of EB: simplex, junctional EB, and dystrophic EB. Each one has at least 10 to 15 subtypes, which are not really essential to know. Just remember what are the clinical manifestations of each type and how will you differentiate each type clinically. So it's not very easy to differentiate the different types of epidermolysis bullosa just on a clinical basis. You need a lot of advanced investigations. You need a gene analysis. You need something which is known as electron microscopy. You need to do a lot of things, direct immunofluorescence techniques. So that is how you can confirm the diagnosis of epidermolysis bullosa and what type of epidermolysis bullosa the child has. So we can only diagnose that this child has epidermolysis bullosa on a clinical basis. We cannot diagnose the specific types of epidermolysis bullosa only on a clinical basis. We need the help of other investigations as well. But there are very specific clinical manifestations which can help us, which can aid us in our diagnosis. And you cannot 100% say that this is this type of EB. I'll just show you what are the predominant clinical manifestations which occur in each type of EB. So EB simplex, like I told you, it affects the more superficial layers of the epidermis. So it is not very severe. So the gene defects here are keratin 5 and keratin 14 are the two genes. If you remember, I also told you the name of another gene, plectin, another component. So mutations in the plectin also cause epidermolysis bullosa simplex. So it's of three types: EB localized, generalized. Localized and generalized are the two types. Again, generalized has generalized intermediate and generalized severe. Okay, so before I tell you about this, let me just show you some images. This is a classical child of epidermolysis bullosa simplex, misdiagnosed by most of the pediatricians, as something which is as simple as an insect bite, but again, it is not so. So the child usually presents with this tense, fluid-filled blister or swelling. Usually, it affects one of the fingers or the extremity. So this is the usual presentation. Let's go back and see. Like I said, minimal and confined blister. So where are they confined? Usually to the upper extremity. So, and also they can also occur on the knees and shins in children who are above the age of 1 year and who have just started walking, who have just started crawling. Why? Because they are the most trauma prone areas. So when the child is crawling, the knees and the shins are the most trauma prone areas, and you can see blisters even in this. In very young children, in neonates, at birth, however, the blisters are mainly seen in the upper extremities. In slightly older children, you can see them on the knees and shins as well. So this was the localized type. So I told you there was a localized type. So in the generalized type, there is widespread and severe blistering, along with nail dystrophy and milia. So let me just show you some images of generalized types. Again, this was another child with who had localized type of EB. This was not diagnosed until later on. So what this was diagnosed as was just irritant dermatitis to the IV. So this child had an IV catheter or an IV line which was put in this area. So Again, this is an example of blisters occurring in the area of trauma. So this child was not diagnosed as a case of EB later on in life. It was just thought to be something which was due to trauma or like a friction blister or a traumatic blister. But in such cases, when you see children, when you see very young babies in the NICU and PICU who have blisters, very tense blisters, especially in the extremities, and you ask for a family history of consanguinity, you always have to rule out epidermolysis bullosa. Okay, so I don't have pictures of, yeah. So this is again, it's not exactly generalized type. This is also localized type, but here you can see that this is a slightly, this picture is that of a slightly older child, and here you can see that the blisters are also present on the feet, on the lower end of the feet and on the palms. So this can happen if the child is, crawling or they are into some form of mechanical activity. Okay, so I don't have a picture of more generalized form of EB, but EBS. So even in widespread, in generalized EB, I told you that there are two types of generalized EB. One is generalized intermediate and generalized severe. Generalized intermediate and generalized severe. You cannot differentiate between these two based on only clinical grounds. There are different genes involved in each one of them, and you need to do a genetic analysis to come to an exact diagnosis. So how do we, but we can differentiate between the localized and generalized type. How? Because in generalized type, there is mucosal involvement, which can be life-threatening. There is also nail dystrophy and the formation of milia. So this was epidermolysis bullosa simplex. Okay, so now let's go to the next form. That is the junctional epidermolysis bullosa. So if you can remember, I told you that junctional EB happens because of lamina lucida. So that is the middle layer of the dermoepidermal junction. So that is why it's known as junctional EB. Again, the two structures, if you can remember, let's just go back to that slide where I told you about the different types of EB. Okay, we'll come back to that later, but just remember that alpha 6, okay, I'll show you the diagram then. This integrin, this alpha 6 beta 4 integrin, let me do it in a different color. This alpha 6 beta 4 and this laminin 332. So which come in the junction of, this is lamina lucida. So these are the two structures which are mainly affected in junctional EB. Alpha 6 beta 4 integrin and laminin 332. Okay. Let's go back to junctional EB. Okay. So laminin 332 and alpha 6 beta 4 integrin, particularly in that beta 4 integrin is more involved than the alpha 6 part. So how do we differentiate junctional EB from EB simplex? So that is the main question here. Like I said, there are a lot of types of junctional EB again, which I'll be telling you in the next slide. We can't differentiate much, but there are certain points which are very critical in junctional EB, that there is little or no trauma. Excuse me for the spelling mistake. There is little or no trauma in junctional EB. So which is the exact opposite of what we studied in EB simplex. So EB simplex happens only in trauma prone areas. So there has to be an external stimulus in the form of trauma for the blisters to form in EB simplex. But what happens in junctional EB is, because the defect lies further down in the skin, you don't need any trauma or any friction. The blisters happen spontaneously. So that is one main difference. Okay. The other very important thing is this right here, periorificial granulation tissue. So I'll show you some images of that. So that is very characteristic of junctional EB. Periorificial, in sense, it can be perioral, it can be periocular, it can be perianal. So these are the three sites, especially where granulation tissue is found. The other important difference here is there is mucous membrane involvement. So that was also there in the severe type of EB simplex, but it is more common in junctional EB. So these are the three differences. One is there is little or no trauma. There's little or no trauma, periorificial granulation tissue, and involvement of the mucous membrane. So these are the three clinical clues by which one can say that this is junctional. This is more of a junctional EB and less of an EB simplex. Again, there are two types of junctional EB. I know this must be very exhausting, but it's important that we know what are the two types. Again, generalized severe and, okay, I'll just show you some generalized. Okay, let's just remember that junctional EB has generalized severe and generalized intermediate. So these are the two types. So this generalized severe, I don't know if any of you have heard of this term. It was previously known as Hurlitz, EB Hurlitz, and it is usually not compatible with life. The usually babies die when they are in the infantile stage. It is very lethal. Why is it lethal? Because of the presence of perioral and perinasal granulation tissue, which also extends down to the mucous membrane. So there are large eroded facial patches and plaques which are extremely difficult to treat, and they usually ooze out a lot of blood and fluid, which leads to electrolyte imbalances, infections, and sepsis in very small babies. Yeah, so let me just show you this. This is a characteristic child who had junctional EB. So here you can see the large plaque, which is perioral. So the red, very red looking friable tissue is nothing but granulation tissue. So that is granulation tissue is characteristic of junctional EB. Again, here you can see a very young girl with very large eroded plaques present on the upper part of her back. These are again very difficult to treat. Okay. So there is mucosal involvement. This is what makes junctional EB very lethal. There is involvement of the subglottic granulation tissue that leads to a weak hoarse cry. And further, if the granulation tissue progresses, it can lead to stridor and respiratory distress. I don't know if you noticed in this picture that this child had a tracheostomy. This was a tracheostomy which was performed in this child because of stridor and a lot of perioral. The perioral granulation tissue is actually an indication that there is involvement of the underlying trachea. So it causes stridor, respiratory distress, and ultimately can lead to death. There is also involvement of the bladder and urethral epithelium. So that leads to a lot of complications, again, stricture formation, phimosis, all these complications. So the other type. So this was the more severe type. Usually infants do not survive with this lethal or Hurlitz type. So if there's a question from a more theory point of view, if there's a question about which is the most severe type of EB, then the thing you should choose is Hurlitz or junctional EB generalized severe. This is the most severe. So this severe word comes in all forms of EB. So you have EBS generalized severe, there's dystrophic EB generalized severe, but the junctional generalized severe is the most severe type of EB. If you have a multiple choice question, suppose for example, which is the most severe type of EB, and the options given are epidermolysis bullosa simplex severe, junctional EB generalized intermediate, junctional EB generalized severe, dystrophic EB generalized severe. The answer should always be junctional EB generalized severe. Okay, so the other one which I told you about, generalized intermediate, so that has usually localized cutaneous and mucosal blistering. It is not as severe as the Hurlitz form, but it is more severe than EBS simplex. So I hope you understood that. So this was EB simplex was the most non-severe form. So more severe than this is junctional EB, generalized, intermediate, and the most severe was Hurlitz's or junctional EB, generalized severe. Okay, so here also you can see a lot of cutaneous and mucosal blistering, but there is no systemic involvement or of the renal tubules, of the urethra or esophagus. So this was a child of junctional EB. Here you can see a lot of widespread erosions, and these are all very large plaques with granulation tissue, so very difficult to treat. Yeah, what you can see here is nail dystrophy. All these are images showing nail dystrophy. This is some scarring, some residual scarring. Again, nail dystrophy. Coming to the last type of epidermolysis bullosa, the last thing which we're going to read today, that is the dystrophic EB. So DEB is short form for dystrophic EB. So like the word says here, it is almost similar to junctional EBs, other than the presence of dystrophy. Okay, so again, for you to understand this, we have to go back to the diagram again, keep visiting the diagram again and again. So this was collagen 7. Let me do it in another color. Okay, so this was collagen 7 here. Yeah, collagen 7. So like I said, the further down it goes, the more scarring it forms. Because why? It's a simple logic. If it's only an epidermal burn, if it's a very superficial burn, usually there's no scarring. So if it's a deeper burn, there is a lot of scarring. So even as the it's similar with EB. So the further down it goes, the more scarring it causes. So it's no shock that collagen type 7. So this is what causes dystrophic EB. Causes a lot of dystrophy and scarring. Okay, so let's go back to the last topic. Dystrophic EB. Yeah. So this is collagen 7. Okay. So just to again revisit our memory, what was collagen 17 was present in the Hemidesmosome. Collagen 4 was present in the Lamina Densa, and collagen 7 is in the Sublaminar Densa. Okay. So there are two forms of dystrophic EB. The recessive R is recessive dystrophic EB and dominant dystrophic EB. This is just their modes of inheritance, whether they're inherited in an autosomal recessive form and an autosomal dominant form. The more common one is autosomal dominant form. Okay, so the characteristic features here, like I said, for the characteristic features in junctional EB was the presence of periorificial granulation tissue. The characteristic feature here is dystrophy of the nails, and the most important one, mutilating pseudosyndactyly of the hands and feet. So this is a very big word. What is mutilating pseudosyndactyly? The syndactyly is a condition where there is joining of the hands and feet. What is pseudosyndactyly? The child isn't actually born with those webbed fingers or webbed hands. It occurs because of scarring. So initially there is formation of blisters, the blisters pop and the fingers fuse together. So that is mutilating pseudosyndactyly of hands and feet. The other important thing to remember here is corneal erosion, scarring, and blindness. Very important in dystrophic EB, doesn't happen with other types of EB. There is erosion of the corneal epithelium, which can lead to scarring and blindness. And there is high propensity to develop squamous cell carcinoma. Let me just show you some images very quickly. So this was a child. So you may think that, okay, there is a lot of periorificial granulation tissue, but the more common, the more important thing in this child was this image. Okay, this is what I was talking about. This is something which is known as mutilating pseudosyndactyly. So here you can see that the child isn't actually born with 3 fingers or 4 fingers. The child is born very normally. Then there is formation of blisters, which then fuse, and then the fingers fuse. Okay, so that is mutilating pseudosyndactyly. Has a very bad prognosis. Again, this is an older child. What you need to remember here is dystrophic EB is not lethal. It is very disfiguring. The quality of life takes a very bad hit, but it is not lethal. The children survive, they grow up to be adults, but they have a lot of deformities and a very poor quality of life. So this was an older girl who was diagnosed with dystrophic EB. She had a lot of contractures over her knee joints, which later had to be released, and she had a lot of difficulty walking. The dystrophic EB is not lethal, but the patients have a very poor quality of life. Okay, so this is the last slide of the presentation. This is just a summary. So before I go to this slide, so I just want to just brush up the clinical features. There was
Ma'am, am I audible? Ma'am, I think you got logged out of the iPhone. Like you're not audible.
hello.
Yes, ma'am. Ma'am, you were on mute the last slide.
Hello. Can you hear me?
Ma'am, can you hear me?
Yeah. I don't know what happened in the end. Can you hear me?
Yes, ma'am. The audio was on mute, ma'am. The last slide.
So go and redo the last slide then, or is it okay?
Ma'am, I couldn't hear. You told it was the last slide and then you went on mute.
Oh,
Yeah.
is it? I'll just revisit the last slide then, and then we'll just finish up in just 1 minute.
Yes, ma'am. Yes, ma'am. That's fine. Ma'am, your iPhone, I think you got logged out of that.
Yeah. Now my video is off, is it?
Yes, ma'am. Video is off and screen sharing is also. I think I can see your screen now. The video is off.
Yeah, that's okay. I think my iPhone got shut off or something. I'll just finish off the last slide just like that, okay?
Sure, ma'am.
Um, sorry, so this was what I was telling you about before. I think there was some problem with my audio. So this is just a summary of what we learned today, a diagram summing up all the types of epidermolysis bullosa. The three types which we need to remember are this one right here, epidermolysis bullosa simplex, which is caused by keratin 5 and 14. These two genes right here, integrin and laminin, which cause junctional EB. And this one right here, type 7 collagen, which causes dystrophic EB. Just to very quickly sum up the clinical features, epidermolysis bullosa simplex. So how do the children present with localized blisters, usually on the extremities? How do children with junctional EB present? See, all the three types of EB present with blisters on the skin and the mucosa. A junctional EB, what is special about junctional EB? You have periorificial granulation tissue. This is what you need to remember. And in dystrophic EB, the special feature here is mutilating pseudosyndactyly. So this is how you majorly differentiate clinically. Like I said, only clinically examining the child will not give rise to the diagnosis. You need to do a genetic analysis, but these were the main three differentiating points. So again, there are a lot of other disorders of the dermoepidermal junction. So what we discussed today was just very brief about epidermolysis bullosa, the three types of epidermolysis bullosa, how do you broadly differentiate them? Okay. Maybe we can discuss about the other types of dermoepidermal junction disorders in the further classes. So if you have any doubts, you can get back to me here on my Instagram profile or my Gmail, or you can also write on the White Army's YouTube channel.